Hi, this is Carlene also, and I have Tamara in here with me.
Okay, perfect. Thank you and welcome.
Thank you.
Okay, so I will jump in. So here is our learning collaborative, our network across the country. As you know, we here in Ohio, we initially had about 12 chapters or 12 practices enrolled in the project. We now have 9. It's been a difficult time, I believe, with everyone's schedules with flu and COVID and everything kind of crazy. But we're still pretty pleased with the number we've had. Additional states participating are Pennsylvania, North Carolina, Utah, and Arizona. So just some ground rules and meeting etiquette for today. If you do have your video, please use it. I am sharing my screen, so it's hard for me to see what everyone is doing. So if you have your video, there, I can see a couple people now. So thank you for doing that. And mute your phone if you're not speaking, so it can be kind of hard to hear some background noise if people are typing. So please, if you're able to, mute your line. Well, we have WebEx on here, but it's Zoom. If you can do on WebEx, I need to change this. So we're using Zoom. If you do have a question or want to speak, please introduce yourself. Please feel free to use the chat box or just unmute if you have any questions or comments. But please do not put your phone on mute. A lot of times we'll hear your hold music, which is wonderful to hear, but not in the middle of a presentation. And we are going to honor the time commitment for the session. So we definitely want to have everyone have a chance to talk. And of course, this call is being recorded, as I said. Okay, so here's our agenda. Real quick, I'm going to run through kind of a welcome to the project, do a roll call, and practice team introductions. Then Dr. Karras is going to take over and give us a couple tidbits for our first learning session in November. Unfortunately, Dr. Kate Crick had a family emergency this morning, so she's not able to join us. So Dr. Karras is going to continue and lead us through our clinical topic, which is leading change. He'll help us through that with some discussion questions. And then at the end, I will wrap us up with some reminders and announcements. So here is our chapter team. So you probably are familiar with some of us, probably me getting emails from me. So I apologize for all of those, but they will continue for quite a while. So Dr. Crick is our physician project leader. And Dr. Karras, I don't know if he's on yet. Say hello if you are, Dr. Karras. I don't know if I see him yet, but he is our subject matter expert. And then of course, I am your chapter project manager. And here's our national team. I do believe that Jennifer, Christy, and Ruth are all on if you want to say hello.
Hi, this is Ruth Gubernick. Nice to see all of you today.
Hi, this is Jennifer Monty. Good to see all of you.
Hi, everybody. Christy Marcel. Nice to join you today.
Thanks, guys, for being on. Admitting people as we go through, so I apologize for the breakup there. We also have Suzanne and Dr. Naik, who are also part of the national team, and we will hear from Dr. Naik. Actually, the presentation that we're having this later on that Dr. Karras is going to walk through with us. Dr. Naik actually is presenting that, and it's a recording, so we will get to hear from him in a little bit. So here are where all of our Ohio practice teams are located. So we have Akron Children's Hospital, Pediatric Associates, Cleveland Clinic, and Metro Health. So welcome and thank you again for being here and being a part of the project. So what we're going to do is I'm going to walk through a slide for each of your practices, and we want to do a quick icebreaker question. So if your physician lead wants to sort of introduce the team and then answer the question, or if your physician lead is not on the call, no problem if you want to select someone from your team to answer the question and introduce everyone. So the question we've selected, name a song that would be included in your COVID-19 quarantine soundtrack. So I will start. The first thing I thought of, and I don't know if it's a bad thing that I thought of this, but REM's It's the End of the World as We Know It. Probably not forever, but for now it is a little different and we're getting used to it. So that is the first song on my quarantine soundtrack. So first up, we have Akron Children's Hospital Pediatrics in Barberton. Do we have someone from Barberton on? Dr. Dwyer?
Yes, hi, how are you?
Good, how are you?
Good, good. I was like frantically looking at the participants to see, I'm looking for a team member. Oh, Anna's on. Anna, do you have a song for us? I'm horrible at these icebreaker games. So I have no idea what song I would do, but maybe if any of our team members, I see Anna is on. She is our office supervisor. We also have all of our physicians in our office who are participating. Doctors Eggleston, Levine, Shookman, Prine, and Collum are all participating. Also, I'm not sure if I've seen if any of them were able to get on the call yet. And our medical assistant, Rachel, is also going to be involved.
Great.
And I do not have a song. I apologize.
We can come back if you have one. Or if
Sure, sure.
If anyone else
I can
on
connect to the
team
computer
has-
some.
Oh, what was that? Oh, I thought I heard somebody else.
It's part of the Barberton thing. I don't think you're involved.
Oh, hey, Jason. We hear you.
Oh, hey. Sorry.
Hey.
Dr. Wells.
Oh, no problem. If you come up with a song for COVID, let me know because I was drawing a blank.
A song?
A song that would be on your quarantine playlist. I picked REM's It's the End of the World as We Know It.
That's a good one. I like that one.
If you can think of one, let us know.
I'll let you know.
Okay.
Thanks, Jason.
Hard being the first
Yeah.
one. You don't have as much time to think. Okay, next up, we have Akron Children's Hospital Pediatrics in Wadsworth. Do we have, let's see if Dr. Karras is on yet. Not yet. Do we have anyone else on the team?
Hi, I'm Dr. Melissa Wang. I'm one of the participating physicians from Wadsworth. And then our other team members are Dr. Saria, Sharon, and Lisa Bates.
Thank you. And do you have a song that you would like to include in our soundtrack?
The only thing that I could think of right now is Let It Go from Frozen.
Yes. I like it. Okay. Next up, we have the Cleveland Clinic Avon Point Pediatrics. Do we have anybody from that team? I thought I saw Rebecca Graham on.
Can you hear me now?
Oh, yes. Were you on?
Okay, I didn't unmute myself. So I'm on. I also don't have a song, but Brenda Wagaman is our clinical lead. Christine Mayer also helping her out, and Melissa Berry is our front desk manager on the project.
Well, thank you. If you think of one, again, feel free. Put it in the chat or interrupt us later. You can always burst out in song if you get over there. Okay, moving on to Cleveland Clinic Strongsville Family Health Center. Do we have anyone from that team on?
Hi, this is Shannon Sikorsky. I'm one of the leads. I wasn't prepared with the song, but I guess the first one that comes to mind maybe is Journey's Don't Stop Believin'. I don't know.
See, that's good. That's really good. And do you want to introduce the rest of your team?
So I'm kind of on the fly right now. Dr. Van Heist is a co-lead with me.
Okay.
I have Kelly Piles and Maya Stojowski and Stephanie Hornsey, who are also on our team.
Perfect. Well, thank you for being here. Okay, next up, we have Metro Health Medical Center with Dr. Carlin. I think I saw Dr. Carlin.
Hello, yes, I'm here.
Hi, welcome.
And I'm busy thinking of a song. And let's see. Should have given us
I know. It's hard to think of them on the fly. If you can't think of one, again, feel free to throw one in the chat.
Yes.
We can put it all together.
Well, all right.
I did think of one.
I'll go back to the classic American songbook, and I'll give you Frank Sinatra, That's Life.
Oh, see, that's good.
That's what all the people say.
Dr. Levine, did
We're
you?
up, we're down, we're over and out.
That's right.
I
Thanks for
get back in the race.
Dr. Levine, did you say you had one?
Yeah, I was just gonna say, waiting on the world to change.
That's
John
good.
Mayer.
That's good. Okay, pediatric associate in Canal Winchester. I think Dr. Stevens is on. I believe he's on. Dr. Stevens, if you're on, you're on mute. Well, we will move past, but this is the team from Canal Winchester. Okay, next up we have pediatric associates in Hilliard. Is Dr. Burkham on or anyone else from the team? I think I see Dr. Burkham on. Are you on mute? Okay, well, this is the team from Hilliard, and we'll have them sing a song later.
I want to hear Jen Burkham sing a song.
I don't know if she's on mute. I see her name, but I don't hear her. Thanks for being on, Dr. Karras. It's good to see you.
Oh, happy to be here.
Okay, next up, we have pediatric associates in Lewis Center. I know Dr. Crick is not available today, as I said, but is there anybody else on the team that wants to chime in and introduce everyone?
So we're gonna kind of chime in with Dr. Burkham since you couldn't hear her.
Okay, perfect.
And our song would be, I think both of our centers, we decided that our song would be, would be Staying Alive by the Bee Gees. That's what Dr. Burkham.
That's good. That's really good. Fingers crossed. No. Looks like she's trying to join back in again. Perfect. Do you want to introduce the team or either one? I know you were kind of in both locations.
Yeah, we're kind of both in both locations. So we can say the Lewis team is Dr. Crick is out today, Dr. Toast, Dr. Blake, I don't think is on. I think they're seeing patients. Tamara and I, this is Carlene. Tamara and I are here in the conference room. And then Dr. Burkham, I'm pretty sure is over in Hilliard working today.
Hi, Dr. Burkham. I miss you.
Can you guys see or hear me?
Yes.
I hear you.
Okay, great. All right, I'm trying to do this from my phone now. Hi, Dr. Karras.
Lovely to see you.
Good to see you as well, and all the other familiar Akron Children's people. So yes, pediatric associates, our lunch is from 1 to 2. So I think some of our providers are popping in and out, seeing patients and trying to listen along. But we are excited to participate, and we are doing our best to stay alive down here.
Perfect. Well, thank you for being on.
Mm-hmm.
Okay. And finally, we have pediatric associates in Pickerington. Do we have anyone from that team on?
Yes, we do. I just got here after seeing patients and I was a few minutes late, but
thank you.
So Dr. Dunley is, I think, listening in too, and we are on the same page of this will all make sense when I am older. Olaf Frozen 2ing for us. So
I like it.
Especially this is what we call controlling what we can when things feel out of control.
Mm-hmm.
That's another Olaf Frozen 2, very applicable to the wonder that is 2020. So
that's good. Do you want to introduce your team?
We have, we actually have 10 physicians at the office, but yeah, like Dr. Burkham said, our lunch is from 1 to 2. So only the people that are not in today are on, I think, but Dr. Dunley, I think, is listening in. Dybel is seeing patients. Long is seeing patients. Burns is at home right now on leave, and Barnes Mullet is seeing patients too. So we're definitely all seeing plenty of teenagers, and looking forward to seeing what we can figure out with all of this. But
perfect. Well, thank you for being on. I appreciate it.
Mm-hmm.
Okay, so typically with these practice webinars, you all have them on your calendars now. They'll run about 60 minutes and they'll typically be facilitated by our chapter physician leader, Dr. Crick, who unfortunately is not here today. But we do ask if you can have at least one core QI team member participate on the webinars, which it looks like everyone has today. So thank you for that. Again, you've received all the information via calendar invite is why you are here today. So obviously that worked. If you need to forward that on to any other additional team members, feel free to do so. So the topics that we'll typically cover are clinical immunization or QI topics. We'll do a data review, and then we'll have practices report out on their PDSA cycles. So we'll look into that more during our first learning session on November 21st. So no need to panic. If you haven't done a PDSA cycle, we'll get some information on that. So you should plan to submit your PDSA worksheets the week prior to our webinars and via Basecamp. So hopefully you're all familiar with that and have received, if not, actually I should ask you, Christy, do they receive information at Basecamp or will they during our learning session?
Yeah, great question, Lori. We'll cover it at the learning session event on November 21st.
Okay, perfect.
And you'll also be invited at that time.
Okay, wonderful. So typically for those PDSA report outs, we'll select 1 to 3 practices each webinar, and so we'll give those practices advance notice so they're not finding a song at the last minute. It'll be a little more prepared. And just to keep in mind, there's no practice webinars during the month of December and when we have learning sessions, so February, May, and August. So just to keep that in mind. So I won't run through all of this. This is all in your onboarding packet, which I'm sure most of you have gone through in some detail, especially since you're pulling your baseline data and all of that. But of course, our primary goal is to increase rates of vaccinations recommended by the CDC, by ACIP, scheduled for adolescents between 16 and 18 years of age. Of course, we're going to look at quality improvement techniques and clinical education and training to increase those rates in pediatric practices. So our learning collaborative is based on the Institute of Healthcare Improvement's Breakthrough Series collaborative model, which includes 4 practice learning sessions and 6 practice webinars, which we're having first one checked off today, in collaborations with the other practices within our region, which is the state of Ohio. So you will have access to subject matter experts, our curriculum, and QI coaching throughout the project. So as we mentioned a couple slides ago, you'll be implementing process changes in your practice by conducting small tests of change in the PDSA cycles. And then of course, you're collecting that practice level data. So the practice is, your participation begins, or did begin in September of this year, and you'll continue through, really through August of 2021 with some kind of follow-up in September. And I'm sure you've seen this as well, but you're all eligible for MOC Part 2 and 4, and then PICME as well. And then here are the data measures that you've all pulled for your baseline data. So just as a little refresher. And next up, I'm going to hand it to Dr. Karras just to give you a couple of tidbits for our first learning session, and then we'll jump into the clinical topic.
Great. So a few things for people to be aware of. Our first learning session is going to be on Saturday, November 21st from 8 a.m. to 3:15. We apologize for taking a Saturday from everyone, but we certainly believe that these are really so important, that nothing's more important to us as pediatricians than ensuring that all our patients are vaccinated on time. And we've got a lot of work to do. Certainly we know that COVID has significantly disrupted pediatricians and practices across the state. We know that our well visit rates took a very serious tumble over the past few months, and we've been working hard to get those patients back in. So we all really need to redouble our efforts to ensure that all patients are getting the vaccines that they need. Hopefully everyone has already registered for the learning session. If you've not, the website is there. It just takes a minute or two to register, and you'll get your confirmation from Lori after. You'll get the Zoom link sent out, and hopefully it'll run all as smoothly as things are running right now. Sometimes things go well, and sometimes it's a challenge, but so far so good. We would need to have all our physician leads to attend, and certainly any available clinical staff should plan on attending as well. And we're really looking forward to that and learning some of the quality tools that we'll be using for this project.
Okay, so next up, we will go over our clinical topics. So I need to actually stop sharing for a second. There is a method to my madness, I promise you. Then I will need to reshare. Make sure I get it correct. Okay. So, Dr. Karish, you want to give it a little introduction?
So this video is by Dr. Neck. It is about leading change in an organization and how we can apply it to our quality improvement. So as we're all watching this, think about how some of these different ideas and topics would apply to adolescent vaccination, and think about any ideas that you can glean from it as we start to think what we can do to lead these changes at our own sites. So go ahead and get started and see what Dr. Neck has to say.
Perfect. Now, fingers crossed.
Hello, everyone. I'm Raj Naik. I'm the medical advisor and consultant for the Improving Immunization Rate Adolescent project for the Chapter Quality Network for the American Academy of Pediatrics. Today, I want to talk to you about a topic that's going to be really important as you all lead change in your chapters and your practices. So we're going to talk about leading change and how it applies to quality improvement. By now, you should have watched a video by Brian Stevenson. Brian Stevenson is the founder and executive director of the Equal Justice Initiative, a human rights organization in Montgomery, Alabama. Under his leadership, the Equal Justice Initiative has won major legal challenges, eliminating excessive and unfair sentencing, exonerating innocent death row prisoners, confronting abuse of the incarcerated and the mentally ill, and aiding children prosecuted as adults. Hopefully, after watching this video, you'll get a little taste of what Brian does on a bigger level in terms of leading change. He's talking about changing the world, and we're going to take some of his principles and use it to apply to how you're going to make changes in healthcare. I first saw Brian speak at the Institute for Healthcare Improvement National Forum in 2017. He was one of the keynote speakers, and I found him to be perhaps the most inspirational speaker that I've ever seen. And he told the story of how he came into his career and how he felt that there was a very close tie between justice and the healthcare system. And really what he does is try to make sure that he's leading positive change by leading the important principles that were highlighted in the video that you watched. To review the principles, he had 4 major principles. The first was get proximate. The second was to change the narrative. The third was to stay hopeful. And the fourth is be willing to do things that are uncomfortable and difficult. These are all very important principles to follow as you lead any change, but especially if you're looking for effective results and certainly it is pertinent to the healthcare setting. So the video, again, is just a small synopsis of what he teaches about. But if you want to know more, he has one of the top rated TED Talks of all time. And of course, there have been movies about him, and he has a great book. Both the movie and his book are titled Just Mercy. And the book really gives you much of the background around the philosophy of these principles. Of note, Bryan Stevenson has won more Supreme Court cases than anyone and has freed many falsely accused, incarcerated people from death row. So he's really an inspirational story. Now, as we start on this talk today, I want everyone to think about their own settings and what they're going to be doing with this project. So the first thing that we're going to do is have you discuss amongst yourselves, what are the greatest challenges you anticipate in leading change during this grant and for improving adolescent immunization rates? You can pause this talk now and discuss.
All right, so maybe things aren't as smooth. What are the greatest challenges that we anticipate in leading change for improving adolescent immunization rates? Feel free to raise your hands or jump in. I'd love to know people's thoughts.
Hey guys, it's Jen Burkham again. Can you hear or see me?
Yes.
Okay, so I would say in this pandemic, I feel like a lot of providers are overwhelmed or fatigued with all the new protocols and discussions you have to have with patients. So, you know, pushing vaccine QI might not be super exciting to everyone, but I think you could argue it's essential right now because we're seeing less people, and if we're seen in the office, we should take every opportunity to get them protected from the stuff we can protect them from.
I know for us, everyone is just so crazy busy. And QI may not be on the top of our agendas. I know at our site this week, we've got a provider on quarantine, another provider who called off today. And so for us, it is all well visits and all COVID all the time. And so there will be challenges as we start to roll out this project. Any other thoughts on anticipated obstacles or challenges?
Dave, can you hear me?
Yes.
My name is Nicole Collum from the Asia Barberton office. I would say education. I think, you know, some of the vaccines, you know, they've been around longer and people are comfortable with them. So, you know, say the Tdap or meningitis, the Menactra, you know, those are more accepted, whereas like the HPV or the meningitis B vaccine, it takes more education to the parents. They're going to ask questions. And again, going back to your time issue, it does take time to do that. So I think us as providers just kind of taking a step back and saying, you know, to ourselves, this is worth it. You know, those extra few minutes, although they might add up throughout the day, it's worth it if we're, you know, helping these kids be healthier.
Thanks, Nicole. I agree. That time to provide that education to families is so hard, especially now with busy schedules, to try to take that extra few minutes to convince someone that a vaccine is important and safe and effective is sometimes hard to really make that a priority when you know you've got other patients waiting. Especially for families that are more vaccine hesitant, and you don't even know if your work is going to make a difference or not. And so to take that time and have that conversation sometimes can be a challenge. So that'll certainly be something that we need to think about as we go through this project. All right.
Dr.
Anyone
Carlin?
else?
Oh, Dr.
Yes.
Yeah, this is Susan Carlin. I completely agree with what others have said. And I see another huge challenge for our population and probably for many patients in your practice, and that's reaching out to adolescents who don't regularly seek care. They no longer make appointments for preventive care because they're teens. They miss appointments. And so reaching the population that doesn't come to see us regularly, I think is a huge challenge.
Thanks. So yeah, I would agree that, you know, for so many of our projects, just getting the kids in for their well visits is the most important part, because once they're here, we can provide all those services and close their care gaps. But reaching out to those families who've not been seen for a while and reminding them that preventive care is important and that they need their vaccines is something that we'll need to think about when it comes to interventions. So let's get back to, go ahead.
You know, especially as they get older. You know, we try to, at Metro, we try to reach out, and I know everyone who has EPIC as their EMR, you can reach out to people through my chart. We do have a school health program. That's an area where we try to reach out to teens, but there's just a big unserved teen population that it's very hard to get them to come in. And when they don't come, then they don't receive these services.
I certainly understand and feel your pain. Thanks. All right, let's get back to Dr. Nake.
Now I want to use a case study. This is a case study using my organization, Gunderson Health System, and how we embarked on improving HPV vaccine rates within my system using the Stevenson principles. Gunderson Health System is located primarily in southwestern Wisconsin, but we have clinics in southeastern Minnesota and northeast Iowa. The system serves about 45,000 children within our catchment area. We have about 150 primary care providers, and we're in 33 clinics, 21 counties, and 3 states. We're a fully integrated system of hospitals and clinics. We have non-vaccination hotspots in our regions. So first, a little bit of background on HPV vaccine, which I'm sure you're all aware of, but just to review and put it into context. In 2006, HPV vaccine became routinely recommended for females 9 to 26 years of age. In 2009, it was approved routinely for use in males. In 2015, I'm sorry, let me restate that. In 2009, it was approved for use in males, and in 2015, it was routinely recommended for use in males 9 to 26 years of age. The Healthy People 2020 goal for children 13 years to 15 years of age was 80%. In 2014, the national average completion rate was just 30%. So a pretty big gap to get from 30 to 80%. Here in my organization in 2014, the HPV vaccine completion rate for females was 45%, and in 2015 for males, it was 32%, so far off from our goal. So we wanted to do a lot better, and we embarked on a quality improvement project with the goal of trying to get to 80% by 2020. So our aim was to improve the HPV vaccine rates in males and females to the Healthy People 2020 goal of 80%. So let me talk to you about the first principle, getting proximate. And I want to reiterate the fact that this is a really critical principle to get right when you're leading any change. When you think about changes in your past or being on the receiving end of a change, a lot of times when the change fails, you can think that it's because of a lack of getting proximate. If you fail this principle, everything else that comes thereafter is going to be difficult. Think how many times that you may have felt about a change coming down from somewhere higher in your organization or health system that, well, they don't know what I do. They don't know what I'm working through or doing on a day-to-day basis. So it's really important when you are leading change in people that you get proximate enough to understand them and understand where they're coming from. So this is not always an easy task. We have about 150 primary care providers for children in 33 clinics, 21 counties, and 3 states. So in our situation, I trained 3 other healthcare providers in primary care, which included 3 pediatricians and 1 family medicine physician, about HPV vaccine and vaccine hesitancy. And I did specific training with my team about how to use the case-based technique. We then traveled in pairs to all of our pediatric and family medicine sites throughout our system to learn about their barriers to vaccinating with HPV vaccine, about their perspectives, to see what their knowledge base was. And then we trained not only the clinicians, but all levels of staff on the best practices for optimizing HPV vaccine delivery, including specific training on the case technique and especially specific to HPV vaccine and the case technique. We learned quite a bit from getting proximate. Here are some of the key learnings. 1, we learned that the majority of staff were actually very dedicated to our mission of delivering the best care for our patients, including administration of HPV vaccine. However, there were many different narratives about HPV vaccine, including some critical misperceptions. There were also some knowledge and training deficits. Also, we found that the clinical and practice variation was pretty significant. And I had remembered thinking at the time, well, we've communicated about this. We've tried to make this standardized throughout the organization. But despite being a fully integrated healthcare system, and despite these attempts at organization-wide education and standardization, there were a lot of unique practice site issues that I was not aware of. Lastly, we figured out that healthcare providers needed point of care tools and training to be effective and efficient. And without being out and proximate to all of these different sites, that might have not been as apparent. So now the next question, and this relates to something we're dealing with now. Getting proximate during the COVID-19 pandemic creates new challenges. What creative solutions can you think of to get proximate during the pandemic? Once again, we'll pause this session now for discussion amongst yourselves.
So I will say that one of the challenges in QI since the start of the pandemic has been the inability to meet with people in person. These types of virtual meetings are fine, and we've been able to get a lot of work done. But we really miss out on that human connection and really getting to hear what people are feeling and going through. So yeah, we'd love to know what other solutions people have on getting to hear what's going on at the site and what we can do to help identify what areas they may have. How have our Columbus people been able to maintain communication between all their sites and hear what's going on? Are you guys in contact? Is everyone in their own little island?
I'll speak to that a little bit coming from Pickerington. We've developed our own COVID task force for how we're doing all of the wonder that is this stuff right now. I think we are finding that we're utilizing technology more and relying on it more. And that's still, I don't know, it still feels kind of like artificially proximate, but we got to do what we got to do. But we're using Facebook to put stuff out there. We're doing telehealth where we can, but obviously you can't actually give a vaccine via telehealth, but sometimes we're able to do that to say, so next visit, why don't you come into the office because you're overdue for your checkup. So then we can set the vitals and get you, get through all that other stuff too. But we're even just amongst ourselves, we're doing this too. We've had several Zoom meetings to try to keep everybody on the same page for things, and email trains unfortunately end up getting stuck in there sometimes too, but face-to-face is a little bit better, but it's still this, this version of face-to-face most of the time for safety reasons. So
Of course, thanks. Anyone else with ideas on how we can get proximate and actually hear what's going on in our sites? I would agree for us, it's lots of emails, and I know often people are overwhelmed with them. And even for this project, we have so many emails to kind of keep track of. It's certainly not ideal, but I think we're all learning how to manage it. All right, Lori, you can keep going.
Now I want to talk about changing the narrative. And first of all, before we change the narrative, we have to talk about the counterproductive narratives that are specific to HPV vaccine. HPV vaccine is sometimes perceived to be optional or not required, or at least it was when we were making our rounds back in 2014 and 15. There's a narrative that HPV vaccine is controversial. There's another narrative amongst healthcare providers that it takes too much time to talk about HPV vaccine. And then there was a lot of our healthcare team members, including staff like medical assistants or nurses, that believe some of the common 10 HPV vaccine myths. And I would argue that you can categorize almost every question you get about HPV vaccine into 10 common myths. We're going to share these myths now because it was really pertinent to how we educated our staff. The 10 myths are that HPV vaccine is too new, that it's too early to give HPV vaccine to patients, that giving HPV vaccine early will make a preteen think about sex or lead to sex, and that some families will couch this as believing in only having one partner in a lifetime. There's the myth that we're giving too many vaccines. So that's not specific to HPV, but it's a common general vaccine myth. That there are toxic preservatives in vaccines, in this case, aluminum. That HPV vaccine is unsafe in some way, and specific ones that you'll hear about a lot are infertility, neurologic problems, cancer, or death. You'll hear that boys don't need HPV vaccine, or that HPV vaccine itself can cause infection. Some believe that HPV vaccine is not effective. And then finally, some will believe it's better to get immunity naturally by getting infected with HPV. Incidentally, this is a myth we're dealing with now with the natural infection as a path to herd immunity with COVID-19 disease. So the next question for discussion is, what are the narratives and leading quality improvement in diverse pediatric practices that you may need to change with regards to this project? Once again, we'll stop for your discussion.
Obviously, vaccine hesitancy and vaccine refusal are some of the biggest challenges facing us as pediatricians. I know that when it comes to HPV vaccine, we have certainly found that having that strong and clear recommendation from the provider has made a huge difference in families' willingness to start the vaccine series. When we did a large project focused on HPV vaccination rates, certainly our providers felt that they were already doing a good job. But when we gave them some of the tools and worked with them on how to present the vaccine more effectively, we did see a very significant increase in our vaccination rates. So I'd love to hear any other ideas that people have or other things that they've tried that have been successful in getting families to accept vaccines, and especially the more challenging ones like HPV and even influenza. What's worked for you?
I'll throw something out there. This is Jenny Dwyer. You know, a lot of times with the HPV vaccine specifically, the parents would be like, I have heard such bad things, or I've read, you know, bad things, or all these side effects. And so I ask them, you know, what have you read and what are you specifically concerned about and what side effects have you heard? And if they can actually answer that question, which a lot of times is just a general feeling that they've read something bad, directly having a discussion about their one exact concern tends to help more often than not. Not always. It's the ones who just, I read or I heard, who don't really know what they read or they heard. Those are the most difficult ones for me, I think.
I think for me, if families bring up their concerns, it's easier to talk about them and talk about the evidence. My biggest challenge is those families who just say, no, we're not doing that one. And even if you try to ask why, they say, oh, we're just not doing it. And don't even give you room to have that discussion. Anyone have ideas on how to deal with families who refuse without giving reasons?
Hi, this is Julie Nunley. I'm part of the Pickerington cohort, and I have that very same problem. I feel like there's a percentage of patients who, no matter what I told them they were going to get their vaccine for, if it was distemper, they would be like, okay. And then there's, you know, the small percentage that are like, no matter what I tell them, it will be, no, we're not getting it, which actually we personally in our practice don't accept people who don't vaccinate at all, but and then we have that middle group that are hesitant, and that's where I feel like a lot of the effort needs to be put, because I feel like there's a lot of misinformation that gets out there about science that isn't explained. So I do feel like that's the population where we really have to focus, because I feel the people who just say no, I could talk to my cat all day long and she won't make that decision either. So you really do have to budget your time. I'm the parent of girls, so I often say, well, my 2 daughters are vaccinated, and I would never ask you to do something to your children that I don't do to mine. And sometimes that's a motivation, but not everybody can say that. So I do feel like there's that middle population. I really don't know what to do with the people that are just like, no, I'm not getting it, especially the HPV. We did change the way our nurses say things. When they walk in the room, they say, you are due for, rather than you could get this one, to act like we kind of expect that it's going to happen. So
I like that, having who's ever rooming the patient really kind of tee it up that that's the expectation, and you know, letting families decline if they need to, but really letting them know that it is the expectation that your child will get all required vaccines. All right, we'll go back to Dr. Nake.
So how did we change the narrative? Well, it was really important to provide the education to dispel these common myths. And then we did a lot of training. We trained our providers how to use the case technique, but now we train both on case technique and motivational interviewing for vaccine hesitancy, but providing them both the education and making sure we dispelled these common myths and the training to help them overcome these common myths at the point of care were really important. Furthermore, we developed a lot of tools to help our healthcare providers that decreased clinical and practice variation, allowed them to be efficient and effective with their counseling. A lot of our tools had to do with some unique stuff we did in the medical record and gave them some great point of care tools, including scripting, direct point of care videos to overcome the myths, giving them efficient tools within the electronic medical record to order the vaccine without having to do a lot of extra thinking. Now I'm going to shift to the next topic, which is, or the next principle, which is be willing to do uncomfortable and difficult things. Well, in this case, there were a number of things that we had to do that weren't necessarily comfortable for the individual providers. One is that we made sure to measure rates, and we did it on a very granular level, meaning down to the individual primary care provider, as well as by clinic site and department level. And then we were transparent about these results. Now we have things on dashboards and reports that we can run to review down to these reportable levels. And then third, also important,